Hi guys, it's Alistair McKenzie here, sports physio from the UK, and welcome back to another episode of Research Unpacked from the Informed Performance podcast. On today's episode, we have Nick Cross. Nick is an Australian sports physio from Melbourne. He is the director of Melbourne CBD Physiotherapy, and he holds degrees in sport and exercise science, physio, and currently reading his master's in sports physio at La Trobe University. He works closely with Ebony Rio, Jill Cook and Craig Purdom and has extensive experience working in AFL, athletics and ballet, where he has a large focus on the management of posterior heel pain. Nick is currently undergoing an excellent research project looking into the clinical practices in musculoskeletal and sports physiotherapists from the diagnosis of Achilles tendinopathy in patients. In this episode, we are going to discuss the rationale behind Nick's project and a case study to pull out some key insights into the management of Achilles tendinopathy, whilst also highlighting some key discrepancies in current diagnosis and management of posterior heel pain.
Today's episode of the Informed Performance podcast has been sponsored by Vald Performance, makers of the NordBoard. The NordBoard has become the gold standard for assessing field-based hamstring strength. By combining advanced sensors, real-time data visualizations and cloud analytics, the NordBoard helps practitioners to accurately measure, monitor and train individuals' hamstring strength or imbalances. To learn more about the NordBoard, visit our sponsor, voldperformance.com.
During a discussion after recording this episode, Nick had kindly agreed to share some excellent video explanations of some of the areas he discusses during this conversation. Please head over to our Instagram account at Informed Performance and scroll to find these great resources. But for now, you are listening to Research Unpacked with me, Alistair McKenzie, and here is today's episode with Nick Cross. Nick, hello and welcome. Thanks for coming on the show. We've been in comms for a while now, so it's great to finally get to sit down and have a chat. How are you, mate?
Very well, thank you. Very well. Thanks for having me.
Now, thank you for coming on. And before we get started, can you just give the listeners a bit of an insight into your clinical and research-based backgrounds?
Yeah, for sure. I guess my clinical background started a long time ago. I came from a sports science background, and then I moved into a master's of applied science and exercise rehab. So I was practicing as an exercise physiologist for a while, and then thought, look, I need to get a better handling on some pathology. Not that EPs don't know what they're doing with pathology, but I just wanted a little bit more depth, and I thought I'd get that back through uni. So I went back and completed a physio degree at the University of Melbourne. And then I practiced for a physio. I've been practicing as a physio ever since. And then since graduating, I went back into a master's of sports physio, which I'm just about to conclude. And then at the same time, through a funny story that we can touch on in a minute, I started completing some research through La Trobe, which is where I was also completing my Masters of Sports Physio in tendinopathy. And I've been doing that for the past, probably just before COVID came around, which is when I kicked it off with Ebony and Jill and Craig through La Trobe.
Yeah, fantastic. I don't think any of those need an introduction, do they? But I know that you've worked in athletics a lot, so that's exposed you to a lot of tendinopathy and posterior heel pain. But can you just share how you got started and got into that?
Yeah, for sure. Like I've always been involved in track and field, even as a little kid. Like I ran competitively, and then as everyone else got quicker and onto bigger and better ranks, I realised that I wasn't able to go as fast as them. So I thought, well, I still really like this sport. And then as a physio, I kind of got more involved on the physio medical kind of front of it and thought, well, I can be competitive in this space. And then I've worked in track and field for a long period of time now for ATS Australia and some other state teams as well. And I guess that's how I became involved with the team at La Trobe in that I was presenting up at a conference in the Australian national titles and was invited up there to talk on management of some tendinopathy from a track and field perspective. And on the journey through and getting this presentation ready, I asked the gentleman who was putting this, sprints conference together, who else is presenting, and he said, I've got this presenter and that presenter, and then he said, I've got Craig Purdom talking on calf injury, and I was like, oh God, I've got to go and present, with Craig Purdom, and he says, well, what's the problem with that? And I was like, do you know who Craig Purdom is? He's like, yeah, nice physio from up north. And Craig's so modest, like, and a lovely, lovely person. Like, he would never tell, how much research and how much he's, paved the way in physio, especially in tendinopathy. And when I explained, he says, oh, well, you'll be right. And so I did the presentation, and Craig watched and kindly went over my slides beforehand and gave it the tick of approval, which I really appreciated. And that night after the conference, we went out for some dinner with a couple of other presenters, and Craig said, listen, like that's a good set of slides that you put together. How would you feel about catching up with some other people who have also got an interest in tendinopathy? And I thought about it for a bit, and I was like, well, more on my plate and no problem. So I got put in contact with Ebony and some of the extended team at La Trobe, and I guess I never looked back since. And I've had a wonderful time working with some great clinical minds and being able to pick some brains of people who really, pave the way in tendon management and will still influence it well and truly into the future.
Yeah, brilliant. And a nice big tick of approval getting that from Craig Purdom must have felt pretty good, mate.
Yeah, look, I think anyone would be pretty wrapped, but it was a bit daunting, but and I still had a couple of things to fix up here and there, so but it was great, and Craig just explains things in a really nice, humble way. So yeah, it's awesome.
Yeah, fantastic. And this episode is going to be a bit different because, like you said, you're in the process of collecting your data for some of the research at La Trobe. So just to kick things off, I really wanted to firstly promote that because I know it's a global research project. Producing a survey on how physios working in MSK and sport diagnose Achilles tendinopathy. And like you said just there, you've got people like Ebony Rio, Craig Purdom, Jill Cook, and the extended team. So it's a big project with probably the biggest names in tendon management. So can you talk a little bit about your project and what paved the way for this? How did you notice that it was an important thing to look into?
Yeah, for sure. I think after presenting at the conference, I caught up with Ebony and we were explaining a few things that were part of my presentation and how we should conduct some research on that. And we discussed that for a couple of months and thought it was a good idea. And then we pumped the brakes on it and said, I think we need to go back a little bit before we try and move forward into some of more of like the diagnostic kind of studies, so we can actually have some criteria to diagnose people with Achilles tendinopathy. And we discussed that for a while, and then I think that when we look back now, we've got to go back to like 2019, and we've got to look at the ICON papers that came out. And there was 3 that were really pivotal that influenced this research. So I should touch on them. And that was the paper on the core domains of tendinopathy. And if we look at this paper, there was a really good group of clinicians and multidisciplinary as well, not just physio, who came together to discuss, the core domains of tendinopathy. And it was agreed in amongst these clinical experts that there are these 9 core domains. And to have a core domain, it needed to be above like a 70% consensus to say, yes, that is a core domain. And we thought about that for a while, and that paper influenced our current research in that we thought, well, these people are all talking together. What are the chances that they've got a pretty similar mindset? So we thought about that. And then we've gone into another ICON paper which is the terminology. So we could say, okay, well, we've kind of got a consensus as to how you might, what are these core domains and what makes up a presentation of tendinopathy, and we know what we want to call it. But if we go into the third ICON paper again in 2019, that says, but if you go back and we look at previous research to say, is there like that nice inclusion exclusion criteria, and it's consistent across a lot of the research, and does the research in the past lend itself to meta-analysis? The answer is no. So we've kind of like, all right, if you kind of blend that all together, that's where this research project came out to say, well, if we've got the core domains, we know what to call it, but in the past, that it hasn't been consistent. I wonder what's actually happening in the clinical world to see whether or not there's that, whether or not the two things are really aligning, or is there a bit of disconnect, I guess. So our project, we thought, well, before we try and pursue diagnostics and getting like a criteria to say that yes, you've got this type of pathology, maybe we should go back and see what's actually happening in the clinical world, because maybe there's a chance that there's not that 70% consensus in and amongst your everyday clinician, and that's not to talk down your everyday clinician, but that's where the general pop and people are seeking an opinion. So we put together a survey, I guess, to then send out to physios who work in sports and musculoskeletal physio to see how they diagnose Achilles tendinopathy. And we thought, well, do we need to get 30, 40 people? And to consider that we wanted to do a global scale, we thought we'd gun for the 1,000, which, at the time we thought would be really easy to do, and it turned out to be a little bit more difficult. And I think we're at about 750. But we thought that would be a good clinical snapshot to see, where the physio sits in diagnosing this condition. And I thought we thought about it for a bit, and we thought, well, we'll go global, because then we can not only see how people do it in Australia, but we can have a look at the UK and America and New Zealand and all over the place. So we've been collecting these responses from all around the world, and we've been doing that for the best part of nearly 2 years, and soon that this trial will draw to a close, and we'll be able to present, I think, some really cool data to then justify why we want to do things into the future, and I think also to really try and bring the two worlds together as a collective.
Yeah, that makes complete sense, and it sounds like it's just important to get a fair lay of the land regarding how clinicians of different experiences and backgrounds manage and assess Achilles-related pain, as well as these clinical experts. So for me, that's right, it's a really important bit of work and a big task for you, and that's why I wanted to get you on the show to discuss the project and use the platform to promote it and hopefully get some of our listeners to contribute and drive it forwards. I've done it, and it takes about 10 minutes to do, and we'll share links on our social media platforms for those listening who would like to contribute. So at the end of the episode, please jump over to a social media and fill it out for Nick and the guys at La Trobe, and thank you in advance for doing that. But as you're in the process of collecting your data, mate, we had the idea together to go through a little case study on how you might go about assessing and managing an Achilles tendon issue to get some of your clinical insights. So how's that sound for you?
That's not a problem. Not a problem.
All right, so let's jump in. So Monday morning, you've got a young, long-distance runner presenting in your clinic with a long-standing history of posterior heel pain. She was previously diagnosed and treated as Achilles tendinopathy on the contralateral leg. For the last 6 months, however, she has had fluctuations in her symptoms, but due to the insidious onset, she thought it would resolve with the same management as her previous injury. So based on that short little snippet, that little window, and based on location and the athlete, what are your key differential diagnoses that you would consider to start with? Where does your clinical reasoning start with, mate?
For sure. I think that when someone comes in with that information, just because they've had Achilles tendinopathy in the past and they've got posterior heel pain, we can't just jump down the line of, well, it's in the posterior heel, it has to be Achilles tendinopathy. Because there's so many different anatomical structures in the posterior heel that can have the ability to present like Achilles tendinopathy. So I think the first thing, the key information is, where is it sore, or where are your symptoms, and where are your symptoms under load? Because I think that's, considering how a tendon works, I think that's the vital piece of information, and you can then start to understand, the structures that might be at play. The other thing is that you want to probably understand is, how long they've had that symptom for, where there's, that's another thing I'd consider, like how the symptoms start. Like, is there a warm-up phenomenon, or does it come later on in a training event? Is it small pinching area or broad region? Because then you might be able to, start to differentiate between like mid portion or Peritene. And so I think trying to take a bit of a like a holistic view at it and not just jump straight down the guts would be my first place to start. Yeah.
Okay, brilliant. Yeah, so not just assuming that she's obviously assumed that she's got Achilles tendinopathy again if the diagnosis was correct on the contralateral. Mm-hmm. But just because they're coming in with that, not just jumping down and assuming that that's what she's got this time, which might put you on the wrong management plan.
For sure. But I think then at the same time, like, when you're looking at certain populations, like, because you've got a runner, like, you could start to think, oh, maybe this is more going to be Achilles tendinopathy like presentation because, of the way the foot and that whole plantar complex acts when you're running, compared to, say, a ballet dancer who goes into repetitive plantar flexion, who's more known to have posterior impingement signs, and maybe similar to a fast bowler who might be saying, listen, I get pain when it's not necessarily when I'm running in, but when I plant that foot and put my weight over it, they're going into that state of compression in the back of the ankle, and that's when I get my symptoms. So, kind of understanding your sport and the clinical population that you're seeing, and then saying, okay, well, what's more likely to be presenting here? And then breaking down, like, when do you get your pain and the location, and especially under a state of load. Yeah.
Yeah, fantastic. Yeah. I worked in cricket as well, and I think pretty much every fast bowler I looked after had posterior impingement signs on their front leg, so the leg that hits the crease. A lot of them train from a young age, so they get osseous changes like osteogonums and stuff like that as well. So yeah, knowing your sport, and like you said, just because she's a runner, may present with more Achilles tendon just because of that energy storage kind of loads. So you've touched on a few little subjective indicators there that would help refine your diagnosis. What other things might you look at, or specifically look at, with regards to pain patterns and loads and angles of loading and stuff like that?
Yeah, I think that, and this is a hard thing to try and explain, so I'll do my best, because I think me personally, as a visual learner, I like to see this in front. But you have to go through like a series of like a progressive loading, and there's a paper that just came out recently that discusses that progressive loading. And so as you're going through a progressive loading protocol, you're seeing that your symptoms are going to be like in particular areas, and they may change if you've got mixed presentations. But as you're taking someone through a progressive loading protocol, that you're seeing that the symptoms stay in relatively same location, and they might, and you should see that in like for instance, like in a mid-portion tendinopathy, that those symptoms will increase depending on as the loading rate goes up. But sometimes, like, you can get thrown a couple of clinical curveballs. I think the clinical curveballs are in more like your mixed presentations, where someone might have, mid-portion Achilles tendinopathy, but then they're also carrying a Peritene and, some signs from the irritation through their Peritene, and they're symptomatic through that as well. And so when you're doing your progressive loading protocol and you're having a look and they're getting pain with isometrics, and then they're asymptomatic through a few other things, it can kind of be a bit confusing. And so I think then it's trying to actually understand the anatomy and what's happening to it in certain degrees of plantar flexion, like you mentioned before. And an example of that might be if you've got someone with a Peritene and irritation, and then there's an increased cellular presence in that sheath, and someone goes into into plantar flexion, that's a state of compression because there's additional cellular response in that sheath, and when you go into that plantar flexion position, the tissue expands and then it compresses the retinaculum, for example, and it might bring about a painful response, and so it's looking and saying, well, okay, is that fitting to what I'm hearing from a subjective point of view? And then trying to decipher and slowly move your way through an assessment that might, take a few little curves along the way to try and tease out exactly what's going on in that structure, if that makes sense.
Yeah, definitely. So there may be, like you said, a mixed presentation rather than just a one, or they could have had an onset of one category of presentation and then led into another one due to the amount of workload.
Yeah, for sure. Like, let's say, for instance, someone's had a mid-portion Achilles tendinopathy and they've been symptomatic for a while, but the symptoms decrease to a 2 or 3 out of 10, and then during a warm up, and then by the time they've finished a warm up, they've gone, and so the athlete doesn't think anything of it. So for 3 or 4 weeks they train through it because it's not so bad. But they present into clinic and they're saying, listen, I've had this pinching feeling for a while, then I've got this big broad region, and the broad region starts to really become problematic towards now the back end of the session. And as a clinician, then you're sitting there going, oh, okay, well, we've got these warm-up phenomenon signs, and so I'm thinking it's mid-portion Achilles tendon pain, but then what's this stuff at the back end? And that can be when you're getting your increased frictional loads for whatever reason, and then that's when they really start to feel like that their pain comes back, and so you can. And those are the tricky situations that you've got to kind of keep a bit of an eye out for, because how you might manage them will be different. And so, to really conduct a thorough subjective, not just on the warm-up phenomenon, but what happens at the back end of the session when it cools down, and then trying to then marry that up in with your certain loading rates, and then states of tissue compression that might be irritable depending on the cellular response that's gone on within that structure.
Yeah, brilliant. So if you're thinking more mid-portion tendinopathy, that would have a positive warm-up effect. It would be under certain angles of load, and then potentially a Peritene would present with more end-range plantar flexion and won't have a positive warm-up effect. It will just gradually worsen and worsen. Is that right?
Yeah, they like someone who might have a Peritene. I said, listen, it's not too bad. Like, I get going, but it's at the back end of the session it gets sore. But then the following morning, it's not too bad when I get out of bed. But I did that for a while, and then and then it could just, as the symptoms get worse or and more pronounced, then they start presenting with a problem. So yeah.
Yeah, so it's really quite layered, which again, bringing back to your research, is why it's really important to understand how people are assessing these, because you could easily see how that might get mistreated in clinical practice. If the diagnosis is different, and they might go on a progressive loading plan with a Peritene and irritation, which might not necessarily improve.
For sure, especially if you're trying to push down the heavy isometrics, and the person saying, "Listen, like it's not making it any better," and then you're trying to move into a, like an isotonic program, and then potentially even then going into states of like negative load, or which will then have the potential to really be quite provocative to that Peritene, and then the person says, "Listen, I'm not getting any better." And I think that when we look back at the research and sometimes with these loading protocols, and we've said, in the past, only 50% of people get better or respond positively to a loading protocol. That could be a potential reason as to why they're not responding. And I think that not that the loading protocol is not going to work, but it's just trying to then, as a clinician, pick apart and say, when do I actually want to apply that intervention? Because, as we just said, in some points, like you will need to manage that Peritene first before you then start hunting. After potentially like a mixed presentation, when you're hunting that mid portion Achilles tendinopathy as well.
Yeah, fantastic. And you obviously know Ebony Rio really well, and her work has been pretty seminal in the loading, and especially around analgesics and stuff like that. And we, from my experience as a fairly young clinician, you kind of get this tendon, you go, oh, so yeah, it's a tendon problem. I'm gonna do isometrics to load, and then I'm going to put them on a progressive loading plan. So really having that detail and understanding of the subcategories of a tendon pain, or what structures are really driving their pain at a certain time frame, at a certain time point, will really indicate whether that's the best protocol at that time. It might be later on that you bring that in and it works really efficiently. How would you go about initially treating a Peritene and irritation? Is it just your basic kind of letting things settle and load management until that irritation, that cellular response has reduced?
Yeah, for sure. Like, yeah, you need to try and bring that under control. And I think that, having a multidisciplinary team is really important in that instance, because if you're thinking that analgesics are warranted, then you might call on your sports physician to assist in that management, and then you can start to use your clinical skills in your stethoscope auscultations to actually hear when that crepitus might be coming down, and then also then to start to compare it back to when you're going back in through your progressive loading protocols as well, to see when like symptoms might be really reducing in certain tests that may have previously been provocative, and then saying, well, okay, things are starting to settle down now, and the person presenting with his posterior heel pain can produce for instance more force and remain asymptomatic. That it might give you a good strong clinical indication as to, okay, I can begin some form of loading protocol with this person. And then you can make that clinical call as to where you want to begin. Do I want to go down the isometrics, or do I want to go isotonics? And personally, from a Peritene, once it started to settle down, I'm more down the line of the isometric. But again, Ebony's research was great, with the isometric theory. But when I'm looking at would I just be applying 5 by 45 seconds to everyone? Well, in a clinical setting, maybe not. Like I might be going a little bit shorter, and how I'm getting that relative load will be very individualized for everyone that comes through the door.
Yeah, brilliant. You just touched on auscultation then as part of your objective. I've never used auscultation in clinic for diagnosis of Peritene and irritation. Can you just describe a little bit about what that looks like as an assessment?
For sure. So someone might say, listen, I'm getting these symptoms at the back end of a run, and it's over this broad region, I'd probably say I'm just looking at my own heel now as we're having a chat, but kind of trending more like not up near your muscular tendinous junction, but above that kind of mid portion region. And when you get the stethoscope and you go through your loading protocol, and they might be sore in certain ranges, and then you go into your stethoscope assessment, you can put someone prone, and you can passively move the foot in and out of, dorsiflexion to plantar flexion with a stethoscope resting on that Achilles tendon, like right in the middle. And sometimes you can hear that quite coarse crackling, and you hear like you should compare to the other side, because you do get a bit of skin movement as well, and you can hear that the stethoscope will pick that up. But you can kind of really hear this distinct kind of grumbly gremlin in the tendon. And, it's a really cool thing to be able to hear, but how sensitive that is, to say like, I don't know yet, but it's a clinical tool that you might, use to draw on a clinical diagnosis of a peritene, and it might just strengthen your clinical reasoning. But how well that works between clinicians, I'm not sure, but I think that it's something that I've used and do use from a clinical in a clinical setting. Yeah.
Yeah. So it might, you're not going to hang your hat on it, but it might just bolster your reasoning based on everything that you've just discussed regarding little subjective indicators suggesting a peritene involvement.
For sure.
That's brilliant, mate. Let's jump on to the next part. So I'm going to give you a little bit more information about our runner. So she is now unable to run due to pain, which is in a broad area of the posterior heel, but there's no pinching, but it does feel like bubble wrap in that region, and it feels, she describes, as quite full. There's no clear warm-up mechanism, and she's noticed her symptoms worsen as training goes on as before. She only noticed during the tail end of the session of high-speed sessions. Additionally, there is no morning stiffness, and she describes her pain now occurring during just walking pace at toe off at mid-range plantar flexion. So there's a lot of information there, but with these new little clinical insights, where's your thought process going? Where's your thought process going now?
I tend to go back to the peritene. That's where my brain goes, especially when they're starting to get that pain at the back end of a session, and in that mid-range plantar flexion, that the tissue in that posterior heel will expand, and it might put pressure on that region. The other thing as well is if you're looking at like shearing and frictional loads in that tendon as well. When we're looking at a runner and we're talking about how much strength they should have in that plantar flexion complex, if someone's deconditioned, through that area, or potentially was symptomatic in the past, which might change their gait mechanics, and it's caused this frictional load. That's something else that you might want to have a look at to say, well, if you've got that decrease of strength and function, and is that actually contributing towards this? If you've got this decreased strength and capability through that complex, is that actually a contributing factor as to why this shearing load actually came about? And so that might be a way to strengthen your clinical reasoning to say, well, okay, I'm thinking it's a peritene, and I think this is also the causative effect of it. So it's kind of a bit of treatment, or it might lead you down that treatment line, but it also might give you an explanation as to why that pathology or that flare-up occurred in the first place. Yeah,
so you're constantly re-updating your diagnosis based on how they respond to your management and your interventions at that time. So let's say, for example, that you've cleaned up the peritene, and now they're presenting like that of a mid-portion tendinopathy, and you're thinking about putting them on a progressive loading protocol. What is your progressive loading plan, and what kind of things do you consider when progressing them from basic calf capacity work to returning to running?
The progressive loading protocol that we use would be like an isometric into like a double leg heel rise, single leg heel rise, double leg jump, single leg pulse, single leg hop for height, and then probably some forward hopping. That'd be the progressive loading protocol that we would use in the clinic. And you can make some modifications to that, whether or not you want to increase or introduce a decline board, and depending on what structures and that you're trying to, and differential diagnosis you might be trying to tease out. But that's the loading protocol that we use, and then kind of coming back into, and then trying to progress from that back into a running based activity. I think that's another whole kettle of fish, in the sense that you're following a progressive, like that progressive load to try and then, come back into some form of running, or wherever that might fit in the spectrum. So, but they may not return back to running straight away, because especially if they've come off like a big Peritene and irritation as well, and they've got poor strength markers, in that plantar complex, and they're under that desired ratio that we're really gunning for in a runner, to say, well, like risk versus reward here. If it's the Olympics or something, okay, and they might roll the dice, but typically from what we see from a day-to-day practice, you've got some time to try and really build that complex up, and that might take months, because depending on where they are in the spectrum and depending on how well they adhere to a strength protocol, and that can take a little bit of time to try and get back up to that desired level to run pain-free. Yeah. And I think then the big thing that we see clinically is, this is just from general experience, like when a patient says, yeah, but I'm not an elite athlete. I'm like, well, what's the difference between you and an elite athlete? And they go, well, I'm like, you're all human. You're still trying to go out and run. You actually need to push, I argue that you need to push the general population a lot harder than probably what they're expecting, to actually get back to a level that's adequate to perform that, task. But I think that the problem that you can have sometimes is the general pop sit there and say, well, there's no pain, I'm good to go. And I'm like, well, no, and so to actually have that understanding about, the force, the force that, the tissue needs to absorb and also generate to run. Once you can explain that to someone and kind of show that what the exercise will do and how you can take them through a protocol to get back to, where they were trying to reach, that you really get that buy-in. Yeah. And then it makes sense.
Yeah. And do you use force plates to show them like some objective data?
Yeah. Absolutely. And I think that when you're looking at from a clinical, like a good clinical pearl, is that, and when we're looking at isometric research, that, that someone says, listen, 7 to 9 out of 10 effort. What the hell does that mean? If you get your force plates and you stand on it, this is the way that we'll calculate it. You get someone to stand on it, and you can get your body weight, and then if you multiply it by your 9.8, you're converting your body weight into newtons. And then if you're pushing into a bar that doesn't move in that mid-range plantar flexion, which is where you should look at, your calf strength, to get a good, accurate, snapshot of where it's at, you can then see how much force that calf complex can actually produce. And we would argue that you'd want to have that 1.1 to 1.3, probably 1.5 times, body weight. And so then you can actually use that as an objective marker, to say not only, you could be good to go back to some running, but But also, if you're going to try and train isometrics, you can say, well, I want to be at 70% or 80% or 90% of that person's maximal effort. So then you can actually have a true loading guide. And I think that when we've done that clinically, someone's been like, "Oh, I didn't realize I could push that hard," and that's a lot harder than what I'm doing in the gym. And so you can then really show someone how much they can actually do.
That's fantastic. So you're doing a true maximal test to get an accurate percentage of where they are. And do you compare that to like the contralateral uninjured limb, or do you just base that on the limb that they're at?
No, you need to compare it to the other side, because the worst thing you could do is go and give them a loading protocol on the one, and then the other side's deconditioned. And people with great bodies are really smart. They'll shift load from one side and put it on the other, and they come back with a problem on the next. You're like, oh, you're forever going round and round in circles. So, it's something that you want to address on both. Yeah, for sure.
Brilliant, mate. So that kind of wraps up most of our key points. You mentioned briefly that, you've taken one step back with the research to take steps forward, trying to get a lay of the land. What kind of research are you looking to do, or where's your thought process for the future after you've got this bit of research out the way?
Well, I think that we'll, generally speaking, without giving away too many of our secrets, I think we need to be able to lend ourselves to meta-analysis, and to do that we need to have some really better inclusion criteria. Like what we're using at the moment just doesn't suffice, and so I think that our research will push down that line, and then I think once we've done that, depending on how successful, I'm sure it'll be successful, but things are always open to change. But I think we'll push down more the diagnostics, and being able to actually say that certain people have different types of pathologies, and then having some nice inclusion criteria for studies in the future will really strengthen the profession of physio, and save us potentially from others saying, listen, no, physio 50% chance, heads or tails, whether or not it's going to work. Don't bother. I think that, but I think we'll get to that later.
Yeah, depth of application is kind of how it sounds. Differentiating between the different nuances of Achilles tendon pain, and being more specific with our treatments based on that. So when you talk about inclusion criteria, including certain categories as opposed to just an umbrella of Achilles tendon.
Absolutely. I think that, we just need to get a little bit more dialed in, and to be able to then rule people in and out of studies. So we're just not ending up with, false positives being included in our populations and sample populations. And I think then, from that point of view, it can frustrate the clinician, and they're going, man, research is slow. This is and it might mean that for the next, I don't know how many years that, we're still going off studies that, are a bit confusing in regards to who they're putting an intervention, or who they're trialing an intervention on. But I think that's when, as a clinician, you've got to really then maybe or potentially just hone in on your clinical experience, and rather than just purely relying on the research alone. But I think the two will eventually really nicely come together.
Yeah, brilliant. I'm really looking forward to it. And again, just for the listeners, we're going to post a link to help complete the survey. It takes literally 10 to 15 minutes. And as we discussed, it's a really important aspect of evolving research to understand what's going on in clinical practice and get the lay of the land to help drive more in-depth and more clinically applicable research data. Is that right?
Yeah, absolutely. And if you're a clinician listening and you're going, I've just graduated and I'm 6 months out, Nick wouldn't want it, and, Ebony wouldn't want to know my opinion. Hell yeah, we do. Because, it's really imperative. It's not just for the clinician that's been 6, 8, 10 plus years out of uni. It's, we're interested in really capturing like an even sample, I should say. And so then we can, see where maybe the education might be missing. That could be another thing we find from the research to say, okay, well, it's more later on down the line that we start to come together, or who knows, but we'll get to that later. But we'll take everyone.
Fantastic, mate. Fantastic. Nick, thanks for coming on. I've really enjoyed our chat. Lots of little clinical pearls in there that certainly will help me in the future and our listeners. Just so we can stay up to date with your research and ongoing stuff, are you on social media? What's the best way to keep up to date with what you're doing?
Yeah, look, we're on social media through LinkedIn, through the practice at Melbourne CBD Physio. And then also all of our research, I'd highly recommend having a look at LASM through La Trobe, who, they do a remarkable job releasing a lot of their research. So you might see me, through LASM or some of our social media channels through work. Yep.
Brilliant. Thanks, Nick. And thanks again for giving up some of your time, your evening over there.
No, that's okay. And look, for the listener, I hope that made some sense and really helps with some clinical practice. So thanks for having me.
Big thank you to Nick for coming on today's show and sharing some of his insights and research into the management of posterior heel pain. To find more Informed Performance content, head to informedperformance.com, where you can find all our episodes as well as articles and also courses from top professionals in performance and sports medicine. And don't forget, you can also find us on social media at Informed Performance on Instagram or at InformedPod on Twitter. Thanks for listening to today's episode of Research Unpacked. Catch us next time for more performance and sports medicine insights.